Kiram for this invitation, and I have been associated with Sir since 2009. I would say that I have been one of his students, and I continue learning from him on a day-to-day basis. I've spent quite a lot of time at Royal Pearl, Trichy, although initially I was trained under Dr. Nishit Shah from Bombay Hospital. So a special thanks to Sir, and I hope a speedy recovery. Hope he gets back to work very soon. And the topic that I've chosen for today is on optic nerve. Optic nerve in ENT, ENT surgeon's perspective of optic nerve, and why an ENT surgeon should be familiar with optic nerve anatomy. So, can I share my screen now?
Yes, sir.
Am I on?
Yes, sir.
Can you just move this folder to the side? Okay. I think I can do it, yeah. Okay.
Yeah.
So very good evening to you all. My topic for today is on optic nerve in ENT, or ENT surgeon perspective of optic nerve. Why am I not able to move this? Can you just see 1 second? Can I just stop and start again?
Yes, sir.
Okay. Okay. So over the next hour or so, I would be taking you through.
Sir,
yeah.
Can you enlarge the screen, sir?
It's enlarged.
Enlarged. Okay, yeah.
Yeah. Yeah. So I would be taking you through.
You have to change to the speaker.
Pardon?
Okay.
Okay.
Yes, sir. Please continue, sir.
Yeah. So I would be discussing this topic under the following headings. That is an introduction. Would be touching upon the anatomy, the physiology, radiology, clinical evaluation, pathology, surgery, and various approaches to optic nerve. Now, why should an ENT surgeon be familiar with the optic nerve? Obviously, with the advent of endoscopic sinus surgery, we have started venturing into the sphenoid sinus, where optic nerve forms a critical landmark. And even beyond, when we talk about skull-based surgeries, we are talking about reaching or breaching the dural barriers, going intracranially, working around the carotids, working around the optic nerve. And the rate at which endoscopic sinus surgery is growing is phenomenal. I mean, from basic endoscopic sinus surgery to skull-based surgery, and now we're talking about endoscopic orbital surgeries. So fairly the scope of an ENT surgeon in these areas is by far is progressing or enlarging day by day. So I think it is something which every endoscopic surgeon should be familiar with, because one of the basic fears of a young surgeon when venturing or starting endoscopic sinus surgery is the fear of injuring the optic nerve or the carotid artery. So these are certain things that one should overcome, or the fears that one should overcome to become a better endoscopic surgeon. So there has been significant attention in the recent past as far as endoscopic sinus surgery and skull-based surgery has been concerned. The advances in the imaging technology, the diagnostic technology, the surgical instrumentations, neuronavigation, reconstructive techniques have helped us reach way beyond what we were able to do a few years ago. Now, coming to the optic nerve, The optic nerve, as you all know, is the second cranial nerve. So it's a paired cranial nerve. The second cranial nerve. And it extends all the way from the optic disc or the optic nerve head to the optic chiasm. It is basically a continuation of the nerve fiber layer of the retina. And embryologically, if you see, the optic nerve arises from the optic stalk. Now, as far as anatomy of the optic nerve is concerned, for the purpose of description, it is divided into 4 anatomical segments. Now, the shortest segment is the intraocular segment, which is approximately 1 millimeter, which is otherwise also referred to as the optic nerve head. Then we have the longer segment, that is the intraorbital segment. Now, the intraorbital segment is confined to this orbit. So it's actually the part of the nerve which is most protected. You can say it is covered, surrounded by muscles, it's surrounded by fat. So this is not an area which actually gets traumatized or injured very easily. Then we have the small intracanalicular portion. So the intracanalicular portion is the part of the optic nerve which runs through a bony canal. So this is approximately 1 centimeter in length. And finally, you have the intracranial course where it leaves the bone, pierces the dura and goes intracranially. Now, if you see the fibers of the optic nerve, we have approximately 1 million fibers. However, when compared to the other sensory nerves, the size of the microns, the diameter is approximately just 2 to 10 microns when compared to 20 microns of the other sensory nerves. And the total length of the optic nerve is around somewhere between 47 to 50 millimeter. Now, once the optic nerve passes through the orbital portion, it goes into a thin bony canal, which is the optic canal. So where this transition happens, there is a band, a fibrous band, or what we call as a common tendinous attachment, which we refer to as the annulus of Zinn. Now, this annulus of Zinn is actually you can see that band here. It is attached to the upper, medial, and lower margins of the optic canal. And this is formed by it is actually the common tendinous origin of the extraocular muscles, basically the superior, medial, inferior, lateral rectus, and the superior oblique. Now, what one needs to know is that there are structures which pass through the annulus of Zinn, and there are structures which pass outside the annulus of Zinn, lateral to the annulus of Zinn. So if you see the second, the third, the sixth, the ophthalmic artery, the nasociliary part of the ophthalmic division of the fifth nerve, all these structures pass through the annulus of Zinn. Whereas the fourth, the frontal and lacrimal divisions of the fifth nerve, they pass outside the annulus of Zinn. So annulus of Zinn is actually not, or does not cover just the optic canal. It also occupies a part of the mid portion of the superior orbital fissure. So that is why you have the other structures also passing in, whereas the optic canal just has the optic nerve coming through it. One needs to be familiar with these terms when you talk about surgeries of the optic nerve, or when you talk about entorbital surgeries. We need to be familiar with the terminologies, that is orbital apex. So when you take a sagittal view, a sagittal cross section, if you see, the orbit tapers down like a pyramid. So as you go posteriorly, it becomes something like a pyramid. So it cones down. So I would just show you a small clipping here now, just to orient you. This is just to orient you. Now this is the left suction optic nerve injury. So the sphenoid is opened. Now, just to explain what the orbital apex is and what the optic tubercle is, this video will probably help. So now this is actually the sphenoid sinus. So you can actually see the fracture line here, fracture spicule. So you come out, start deroofing the lamina, start elevating the lamina out. And when you elevate the lamina, you can actually make out this V-shaped appearance here. So how the apex forms. So it starts coning posteriorly, or it becomes something like the apex of the V. And right at this apex, so you can actually elevate the thin lamina, you can flake it off. And then as you go posteriorly towards the orbital apex, there's a thick ledge of bone, right lateral to the annulus, which we refer to as the optic tubercle. So this usually cannot be elevated easily. So now if you see, I'm drilling off the optic tubercle. So the orbital apex, This is the base of the skull. So you can see how it tapers. And once the optic tubercle is drilled, you see this whitish band here, which is your annulus of Zinn. And once you drill out and expose the annulus of, so at this point, now if you see, you can see the fibrous band, and then finally you can see how the optic nerve takes a superior course from the orbital apex. So it is not in line with the apex of the orbit. Rather, from the orbital apex, it takes off slightly superiorly. So that is orbital apex and the optic tubercle. Now coming to the osseous anatomy. So when you talk about the orbit per se, as I told you, it's a pyramidal structure, the apex away and the base towards you. And remember the rule of 7. So when I say the rule of the 7, it means that the orbit is formed by 7 bones. It has 7 muscles, and there are 7 nerves that pass through this various foramina. Now, when you talk about the optic canal, so optic canal is the canal through which the optic nerve passes from the intraorbital course, gets into the intracanalular course. So I told you that it measures roughly around 1 centimeter in length. Now, this is formed by the lesser wing of the sphenoid. So when I say the lesser wing of the sphenoid, the anterior clinoid process is a portion of the lesser wing of the sphenoid. And this anterior clinoid process has an anterior root and a posterior root. So the anterior root goes medially over the optic canal, whereas the posterior root is what goes on to become the structure that we commonly refer to as the optic strut. So the relevance of this optic strut, and just lateral to that. So if you see this fissure, this is the superior orbital fissure. So this optic strut is the structure or the bony landmark that separates the optic canal from the superior orbital fissure. And if you see the optic nerve per se, it's covered by the layers of the meninges. So basically you have 3 layers of the meninges encovering it. Now, and when it comes anteriorly in the orbit, now the dura and the periosteal layer fuse to form the periorbita or the orbital periosteum. And one important structure that passes with the optic nerve is the ophthalmic artery, which usually is located inferolateral to the optic nerve. So when you see from an endoscopic perspective, we are fairly safe or away from the ophthalmic artery. Whereas if you're talking about an external approach, that is something that the neurosurgeon needs to be careful about. Now the osseous anatomy, again continuing with that. Now if you see, the optic nerve canal is located in the superior and the medial aspect of the orbital, the pyramid. So it is in the corner, whereas the superior orbital fissure is slightly laterally placed. And as I told you again, once again, I would just emphasize on the concept of that optic strut, which is very important as far as endoscopic surgery is concerned. So that is nothing, but it's a posterior root of the anterior clinoid. It separates the optic nerve from the optic canal from the superior orbital fissure. And once it transverses through the optic canal or the canaliculus, then it goes intradurally. And there it goes on to meet the optic nerve from the opposite side. And there is decussation of fibers, and we have the optic chiasm. So optic chiasm, when compared to the optic nerve, is a flattened structure, which is more horizontally widened by around 12 millimeter and an anterior posterior dimension of around 8 millimeter. And this is ensheathed by the pia. It's surrounded by CSF. Now this is a transcranial view. So you can see once it leaves the optic canals, once it leaves the bony canal, you can see how the nerve travels posteriorly through the anterior incisural space. And so this is basically the supracellular compartment. That is where your pituitary would be. And these are the carotids on either sides. And this particular ledge of bone is the clinoid process. So it actually transverses medial to the clinoid process. So it passes medial to the clinoid process, runs posteriorly, slightly medially and superiorly, and eventually forms the chiasm. So as I told you, it's a flattened structure, horizontally around 12 millimeter. The AP diameter is around 8 millimeter. And from here, again, they continue as optic tracts. So you can see the optic tract taking off posteriorly on either side, and that travels posteriorly and laterally. In other words, the optic nerves, they cross over, and then again, they diverge and continue as the optic tracts. Now, what the optic chiasm does is it divides this, you see, this is the optic chiasm. This is an endoscopic view. When you see endoscopically, it divides or provides us with two spaces. So one is the suprachiasmatic area, the area above the optic chiasm, and you have a subchiasmatic area, that is the area below the optic chiasm. Now, suprachiasmatic area, now this is the area where you encounter the A1 on either sides. Communicating them is the anterior communicating. Then you have the A2. You can see the gyrus recti. And you can also see a branch here from the A2, which is probably the artery of Hubner. Now, if you go into the subchiasmatic area, so that is what we saw in the first slide. Now, here, if you see, this is optic nerve, the optic chiasm. So the optic nerves on both the sides forming the optic chiasm. And in the subchiasmatic area, what you get to see is the pituitary stalk. You get to see the pituitary stalk, and you also see the first intracranial branch, which comes out from the internal carotid. That is a superior hypophyseal artery, which supplies the pituitary. You can also see the branches, the descending diaphragmatic branches, and also branches to the optic chiasm per se. So these are the two areas that we can approach: above the chiasm, below the chiasm, depending on what kind of pathology we have to tackle. So, and behind the pituitary stalk, you can see the basilar artery. Now, why is the pituitary, why is the optic chiasm important? So you can have anatomical variations in the position of the normal optic chiasm. The most common position that we come across is the central position. So when I say central, it means it lies directly over the cella. So if you see here, now this is the normal position. So if you see, this is the pituitary gland, the stalk. So you have the optic chiasm lying just above the cella. So what happens in these kind of scenarios? So this is what contributes around, I would say 80 to 85% of the patients would have a centrally placed chiasm. Now, when you have a pituitary tumor in these kind of patients, the tumor enlarges and it actually involves the chiasm first. So that is where you classically get the homonymous hemianopia. Now, if it's a prefixed chiasm, so what happens with the prefixed is that the chiasm will be located anteriorly and it will actually be directly over the tuberculum sellae. So in those kind of situations, if the patient has a pituitary tumor, usually the optic tract would be involved because the chiasm is placed more anteriorly. The tumor tends to spread superiorly and go on to come in contact with the optic tract. And the third scenario is the postfix chiasm, where you see the chiasm is located behind the tuberculum, behind the cella, and almost directly above the dorsum sellae. And this kind of cases, when you have a pituitary tumor enlargement, it's usually the optic nerve which gets involved first. So this is the important. Now again, this may not be much of an importance for an endoscopic from an endoscopic perspective. However, now the position of the pituitary stalk also varies with the position of the optic chiasm. So when planning transcranial approaches to the pituitary, this is something what probably the neurosurgeon would have in mind, looking at the location of the chiasm in relation to the tumor. Now, for completion, the optic tracts. Now, as an ENT surgeon, we obviously would not be dealing anything much with the optic tracts. But what happens to the beyond the optic chiasm, the optic tracts, they run outwards and backwards. So from the posterolateral aspect of the optic chiasm. And these, so what one needs to understand is when you talk about the optic nerve, you have nasal fibers and temporal fibers. So at the optic chiasm, there is decussation of fibers. That is the temporal, the nasal fibers, they cross over from either sides. So finally, when the optic tract continues posteriorly, it involves fibers from the temporal half of retina of the same eye and from the nasal half of the opposite eye. And then these fibers go on to terminate at the lateral geniculate body, and from there to the visual cortex, and finally end up in the occipital lobe, which is basically the visual area. So this is actually the entire visual pathway we are talking about. Now, physiologically, as far as vision is, obviously when you talk about the optic nerve, you always talk about vision. So whatever images fall on the retina, these signals are carried to the brain or to the occipital lobe via the optic nerve. Now, it carries afferent fibers of pupillary light reflex, the efferent being the oculomotor nerve. And what makes the optic nerve different, or why is it different from other nerves? Now, unlike the other peripheral nerves, the optic nerve is not covered by neurolemma, and it does not have the ability to regenerate. When you talk about facial nerve injuries, there is always a possibility of the facial nerve regenerating. You can use a cable graft, you can decompress. Now, even if a part of the segment is cut, the nerve has the ability to regenerate. Whereas if you see the optic nerve, you cannot think of grafting, you cannot think of suturing, you cannot think of anastomosing, because once it is cut, it does not regenerate. And that is one of the reasons why earlier, one of the biggest promises as far as optic nerve injuries were concerned was the role of stem cell therapy. There was a big hype on the role of stem cell therapy in optic nerve injury, but unfortunately, it did not live up to its promise. And we hardly hear anyone talking about the role of stem cells in optic nerve these days, although initially it was something which was hyped about. So as long as the nerve cannot regenerate, there is nothing that you can do about it. Now, coming to the blood supply of the optic nerve, so it's fairly complex in the sense every segment has a supply from a different source. Now, here, if you see, this is an axial section. Now, you are looking at the right eye. So the yellow structure is the optic nerve. And here you can see the supraclinoidal internal carotid. So the ophthalmic artery takes out, or is usually given off from the supraclinoidal internal carotid artery. Occasionally, it can come out from the cavernous portion of the internal carotid artery. So as I told you, the relationship with the optic nerve is that it runs inferior and lateral. And once it comes out, you can see it gives out one of the main branches, that is a central retinal artery. So this is probably one of the main branches of the ophthalmic artery, and this is what is actually involved with vision. Now, if you have a central retinal artery injury or a central retinal artery occlusion, the patient has loss of vision. And if you see, there are a lot of other branches which come out from indirectly from the ophthalmic. You have the lacrimal branches, you can see the supraorbital branches. Now, as far as an ENT surgeon is concerned, two important branches which come into the sinus or which run into the roof of the ethmoidal sinuses are the anterior ethmoidal artery and the posterior ethmoidal artery. So this is something that we usually routinely encounter during endoscopic sinus surgery. And this anterior ethmoidal artery continues still further up the fox as the falcine artery. So it can actually be a feeder to tumor arising from the fox. And you can see all the other, there are a lot of terminal branches like the posterior ciliary, the central collateral, the anterior choroidal, the posterior choroidal. So you can see there are a whole lot of tiny branches supplying different segments of the orbit. And you can see it's a fairly complex vascular supply. So the nerve actually takes off from the lateral aspect, then it crosses on the superior aspect, gives out branches, and you can see the umpteen number of anastomoses that happens here. Now, very rarely, you can also have the ophthalmic artery taking off from the middle meningeal artery as well. Very rarely. Now, when you talk about the optic nerve, it also forms boundaries to certain important landmarks in skull-base surgery. Now, we very often keep talking about the LOCR, or the lateral opticocarotid recess, the medial opticocarotid recess. When you talk about the lateral opticocarotid recess, this is nothing but it is a pneumatization of the anterior clinoid. So now here, this is a dissected specimen. So just to orient you, now this is the midline, this is the sella. Now that is actually the basilar artery. The whole carotid segment has been exposed. The entire bone has been removed. You can see the optic nerve running here. And if you see, there's a small dimple here. So this dimple or this recess is what we describe as a lateral opticocarotid recess. Now, why is it called the lateral opticocarotid recess? Optic carotid. So the boundaries are found by the optic nerve and the carotid. So if you see here, superiorly it is bound by the optic. In the medial aspect, you have the carotid. And inferiorly, this is the third cranial nerve. So this is a structure which may be very prominent if the bone is well pneumatized, if the anterior clinoid is pneumatized, or it may just appear as a very subtle or a simple pit, may not be very obvious. So the pneumatization varies, the appearance of the lateral opticocarotid recess can vary. And these, now for example, now if you see in this particular case, now you can see the entire sphenoid is opened and you can see the lateral opticocarotid recess on the right side of the patient, and you can see the lateral opticocarotid recess on the left side of the patient. Here you can see how deep it is pneumatized. In the same patient, you can have variations in the pneumatization of the opticocarotid recesses. So you can see the optic nerve, you can see the carotid bulge, which may not be very prominent on this side. Now, similarly, you have another important landmark, the medial opticocarotid recess. However, the medial opticocarotid recess may not be as prominent as the lateral opticocarotid recess. So what is the medial opticocarotid recess? Now, if you see, look into the literature, there are various ways of describing medial opticocarotid recess. So you can see here now how obvious the lateral opticocarotid recess is. You can see the optic nerve, you can see the carotid. And if you remove this bone here, you would actually see the third cranial nerve. Whereas the medial opticocarotid recess is actually the confluence. So where the optic nerve comes and ends, where the intracanalular portion of the optic nerve ends and it starts becoming intradural, where the clinoidal segment of the carotid ends and goes supraclinoidal, where the sella comes and meets the tuberculum. So the confluence of this area is what we call as the medial opticocarotid recess. So it is not a well-defined landmark. And this actually corresponds to the middle clinoid process. So if you see, now this is the transcranial view. So if you see, you can see the optic canal, you can see the anterior clinoid process. This is optic strut, which separates the optic canal from the superior orbital fissure. And this is the middle clinoid, which corresponds to the medial opticocarotid recess. Now, this is of relevance in especially tall tumors. When I say tall tumors, tumors which extend vertically upwards. So it could be something that we commonly encounter in pituitary surgery. We can have this snowman configuration tumors or a dumbbell-shaped tumor. So it is very important that this portion of the bone is decompressed so that it helps the vertical tumor to fall out easily into the field. Now, again, just to continue with the medial opticocarotid recess. Now, as I told you, so it's a confluence. So you can see the carotid, you can see where the optic nerve merges in. So the bone between both these optic nerves is the tubercular strut. So the medial opticocarotid recess is nothing but the lateral edge of the tubercular strut. So by opening up this area, you can get an access into the supracellular cistern, the lateral recess of the supracellular cistern. And at this point, I would like to emphasize on one more thing. Now, the optic nerve as such also forms. Now, if you see, we talk about the different divisions of the carotid. Now, there is something called as a clinoidal segment of the carotid. So if you were to define the clinoidal segment of the carotid, now if I can draw a line along this upper segment of the lateral opticocarotid recess and a line along the lower segment of the lateral OCR, the segment of the carotid within these two lines is what we refer to as the clinoidal segment. So again, that is how the optic nerve forms a relation in defining the segments of the carotid as well. Now, pneumatization of the sphenoid bone. So I did talk about lateral opticocarotid recess. So every patient, you would not see it as a very prominent recess. Now, all this would depend on the pneumatization. So one has to be familiar with the pneumatizations of the sphenoid bone. So this is a very common picture that we talk about. So we have different kinds of pneumatization. It could be something like this, where there is hardly any cavity within the bone, the conchal kind of pneumatization. It can be the pre-cellar, where you have a pneumatization confined just to the anterior part of the cella. So if you were to draw a line along, perpendicular line along the anterior wall of the cella, the pneumatization would just be confined to the anterior portion. Or it could be post-cellar, where the pneumatization can extend all the way inferior to the cella and also all the way up to the clivus. So in these kind of situations, you are likely to see a fairly obvious or prominent landmarks within the sphenoid sinus. Now, coming to clinical evaluation. Now, one of the most important assessment as far as optic nerve pathologies or optic nerve injuries are concerned is a fundoscopic examination. Now, when you talk about fundoscopic examination, what we look for is basically the optic cup. So basically, we are having a look at the optic disc or the optic nerve head. Now, the evidence of papilledema, where you have blurring of margins, pallor, all these are suggestive of uh, optic nerve pathology. Similarly, something that we need to keep in mind is the fundoscopic, in fundoscopy is when you have a patient with optic disc atrophy. So if the optic disc is atrophied, no matter what you do, the patients will not regain their vision. So when you have an optic disc atrophy, you are fairly more sure that this patient is not going to have any recovery of vision. So why does papilledema set in? So there is disc swelling in papilledema. So what happens is that there is flow stasis, the axoplasmic flow stasis, which leads to axonal edema. And what happens is there is, as I told you, the optic nerve is surrounded by layers of the dura. So it is continuous with the subarachnoid space. So the CSF pressure increases and this pressure gets transmitted to the optic nerve. And there is something like a tourniquet effect. So the optic nerve sheath acts as a tourniquet and the nerve gets compressed. And a very popular assessment or a test that we use in assessing patients with optic nerve injuries is relative afferent pupillary defect. And I think this is probably something that all of us should be familiar with if we are dealing with traumatic optic neuropathy. Now, because most of the times we will have a bedside assessment for these patients. These patients may not be ambulatory. These patients may not be in a position to be shifted to the OPD for detailed evaluation. So the crux or how you go about performing a relative afferent pupillary defect, the initial step is to ask the patient to focus at a distant object. So when that is done, the pupils are dilated. The next step is to assess the normal side. So take a torch, shine light onto the normal side. So you have two reflexes, that is a direct light reflex and a consensual light reflex. So the direct light reflex means when if I shine light into this eye, the pupil will constrict. And simultaneously, the pupil on the opposite side should constrict. And then swing the light to the other side, the affected side. So what happens is that there will be a temporary paradoxical dilatation of the pupil. So ideally, if the patient has normal vision, that pupil should remain constricted. So if there is a temporary paradoxical dilation of the pupil, this indicates that there is a defect in the afferent limb of the eye which you have tested second. So you may have to repeat this couple of times to appreciate this. Now, is it foolproof? That is a question. So pupils respond differently to light stimuli shown in one eye at a time due to unilateral or asymmetrical disease of the retina or optic nerve. So it is very important or mandatory to ascertain or to get a history if this patient has any preceding or pre-existing retinal or optic nerve injury, which you may not know. So you would probably be testing this without knowledge and you would probably come to an inference that probably the patient has an optic nerve injury. But the patient probably could have had a previous retinal pathology which you are not aware of. And this particular test is called as a swinging flashlight test. And this response is called as a Marcus gun pupil. Now, so as I had already mentioned, so each pupil will constrict quickly and equally during exposure to direct light, which is direct light reflex, and to light directed at the other pupil, which is called as the consensual light reflex. Now, however, the limitations of this test are, now if you have a patient with dark iris, you may not be able to appreciate the pupillary reactions. Similarly, you can have situations where the patient has a pre-existing asymmetry of the pupils. So there is something called as anisocoria, or if this patient has an efferent defect, something to do with the third cranial nerve or the oculomotor nerve, this test may not be reliable. So these are certain situations where you need to think of. Because recently we had an issue. We had operated on patient of a CSF leak, a revision case, which was operated earlier twice, and we had to redo the surgery. And in the evening, my resident gives me a call saying that the patient has asymmetry of the pupil. Now, because I knew this patient earlier, so we had documented that this patient had a pupillary asymmetry from the time he had a road traffic accident. So it is important to go back into the history and to make sure that you don't miss out on any of these findings before you come to a conclusion with a swinging flashlight test. The next important assessment would be assessing the visual acuity. Now, when we talk about visual acuity, now this is the Snellen's chart, which is universally followed. Now, something that you would come across is this marking. So normally you would have seen an ophthalmologist evaluating this patient, putting up a finding saying vision is 6/6, 6/9, 6/60. Now, in certain, if you go into the Western literature, you may come across findings saying vision 20/20, 20/200. Now, what are these? So when you talk about the 6/6, 6/9 classification, this is basically in meters that you're talking about. Whereas if you look at the American literature, now they follow the 20/20, 20/200 system, which is in feet. So when I say a patient has 6/6 vision, it means what a patient, a normal individual or a patient with a normal eyesight is able to see at a distance of 6 meters. I am also able to appreciate at a distance of 6 meters. Whereas if I say my vision is 6/60, that means what a normal person can appreciate at a distance of 60 meters, I am only able to appreciate it from a distance of 6 meters. So 6/6 would correspond to the 20/20 in the American system, and 6/60 would roughly correspond to the 20/20. So this can be confusing. So it's important that you have an idea about what system you're using. Now, this is very important as far as documentation is very important. In decision making, again, visual acuity is an important factor. And when it comes to prognosis, when you want to monitor the outcomes, again, you have to have a charting of the visual acuity. The next important thing is color vision. So when you talk about color vision, you talk about the color testing of the Ishihara's chart. Now, classically, most of the literature, it said that the red color is the first color to be affected. But if you see, although you really do not have any clear-cut reasons as to why red should be most commonly affected, but most of the literature says that it can either be the red-green combination which gets affected, or it can be the blue-yellow combination which gets affected. So the color vision can get affected in optic nerve injuries. So this is actually a layout of the anatomy that we had described earlier, how the optic nerve passes. So you can see these are the temporal fibers, the red, these are the nasal fibers. Then they pass. So this is the pre-chiasmatic area. Then once they come into the chiasm, you can see the temporal fibers continue as such, whereas the nasal fibers cross over. So you have the nasal fibers from this side coming to the opposite side, and the nasal fibers from this side going on to the opposite side. And then, as I had already mentioned earlier, you have the optic tracts, then you have it going on to the lateral geniculate body, and then finally to the occipital lobe. So that is the entire layout of the visual pathway. Now, probably our discussion as far as visual fields or perimetry is concerned would be confined more or less to the level of the optic chiasm, as far as an ENT surgeon is concerned. So if you have a complete transection of the nerve, so if you have a complete transection of the nerve in the orbital part or anywhere anterior to the chiasm, what you will end up will be having a monoocular or ipsilateral monoocular visual loss, a complete loss of vision. Whereas if the lesion is at the level of the optic chiasm, which is the most common visual field defect that you encounter in a pituitary tumor, you will end up with a bitemporal hemianopia. And if it's still posteriorly beyond the optic chiasm, you'll end up with something called as a contralateral homonymous hemianopia. And there are other visual field defects which are predominantly of interest to the neurosurgeons and the neurologists. Now, some other important tests which can be useful in evaluation of patients with optic nerve pathologies. One is visual evoke potential. So as the name says, it's an evoke potential, so to a visual stimuli. So by placing electrodes over the occiput and by giving a stimulus, we record certain patterns. Now, this actually gives you an idea about the visual pathway. Now, this is an excellent tool for assessing lesions anterior to the chiasm, anterior to the optic chiasm. So it could actually pinpoint or tell you where exactly the site of pathology is, but however, it may not tell you the type of pathology. Now, the disadvantages of this is that it cannot be done as a bedside test. It has to be done in an OP setting, and I think the question of availability is something that we need to look into. But this is something which has shown promising results as far as optic nerve pathologies are concerned. Now, another important test is the retinography. So this basically, in this test, you measure electrical activity generated by cells in the retina in response to a light stimulus. However, these are predominantly reserved for pathologies of the retina and the macula, and not very specific for optic nerve pathologies per se. Now, coming to the radiological aspects. Now, when you talk about radiologically, CT scans and MRI both do have their role as far as imaging of optic nerve pathologies are concerned. And this is probably one of the most popular classifications, that is the Delano's classification, where he has described the different patterns of optic nerve in relation to the sphenoid and the posterior ethmoidal cells. I mean, it's not something that you need to know by heart, but then it is. Now I will just show you the examples here. So this is the type 1, which is the most common type, where you have, this is the anterior clinoid. So this is the sphenoid. You can see the intersphenoid septum. And you can see the optic nerve here, but it does not actually create an indentation into the sphenoid sinus. So you have an optic nerve. So in these kind of cases, if you are to do an endoscopy, you're not going to see the prominent bulge of the optic nerve. Now the type 2, if you see here, there is slightly more pneumatization of the anterior clinoid, and you can see that the optic nerve actually takes a dip into the sphenoid sinus. So you will actually be able to appreciate the bulge of the optic nerve within the sphenoid sinus. Now 3 and 4 are basically seen with extensive pneumatization of the anterior clinoid. So if you see, there is air around the entire optic nerve. So if you see, this optic nerve is actually intra-sinus. It runs within the sinus. More than 50% of the nerve is within the sinus. And in this itself, you can see the fourth part, the fourth type, where the optic nerve is related to an anode cell or a posterior ethmoidal cell. So if you see, there is a horizontal partition here. You can see this is the sphenoid sinus, and the nerve is actually related to the posterior ethmoidal cell. You can have variations of the optic nerve. Now, for example, in this situation, what one needs to be aware of is to look out for any bony dehiscence of the optic nerve. So before you venture into the sphenoid, make sure that you don't have an exposed optic nerve or an exposed carotid, which are both equally important when opening up the sphenoid sinus. Now, MRI, if you see here, you can actually trace the entire course of the optic nerve. So all the way from the intra or the ocular portion, the intraorbital course, the intracanalular course, and if you see still go posteriorly, you can actually see the portion of the optic chiasm. So all these areas can be clearly mapped on a MRI. Now, what are the other things that one needs to look into other than pathology? So you obviously, when you have tumor in these areas, you can see the relationship of the tumor to the optic nerve. You can see if it is compressing, if there is a fracture, all these things can be made out. So this is just one simple example. Now, if you see the sagittal cross section here, you can see the tumor here within the cella expanding up superiorly, and you can actually see the optic chiasm superiorly. So the tumor actually impinges on the optic chiasm. The same thing, if you are to see on a coronal cut, you can actually appreciate the relationship or the indentation caused by this tumor on the optic chiasm. Now, what other additional information does the optic nerve imaging give you? Now, we have conditions like idiopathic intracranial hypertension. So when you talk about idiopathic intracranial hypertension, there are a lot of controversies. So there has been guidelines or diagnostic. I mean, there are certain diagnostic criteria for coming to a diagnosis of idiopathic intracranial hypertension or benign intracranial hypertension, and one amongst them is the radiological criteria. So there is something called as a modified Dandy's criteria. So if you see radiologically, if you can see this vertical buckling of the optic nerve on an MRI, you can see the scleral flattening or the indentation. That is another finding. You can actually see the empty cella. The cella is filled with CSF. So you can see the tortuosity of the optic nerve, the peripheral halo around the optic nerve. So all these are part of idiopathic intracranial hypertension, but an isolated empty cella or a finding of a peripheral halo around the optic nerve need not be a case of an empty cella. So you need to have other clinical, you need to have papilledema on fundoscopy with monitoring of CSF pressures and other radiological findings to come to a conclusion of idiopathic intracranial hypertension. Now, pathologies of the optic nerve. So when I talk about pathologies of the optic nerve, so just like classification of many other pathologies, it comes under different headings. Congenital, hereditary, demyelinating disorders, inflammatory pathologies, neoplastic pathologies, ischemic causes, and miscellaneous causes. Now, as far as ENT surgeons are concerned, we do not have much to do, or there's not much of a role with most of these. But then what would be important or what would be relevant is obvious, probably case of optic neuritis. So optic neuritis is a condition where you have an inflammation of the optic nerve. So when you have inflammation of the optic nerve, it can be an isolated optic neuritis. It could be secondary to a sinus pathology. So if you have an inflammatory pathology within the sphenoid sinus, it could erode the bone and the patient could end up with an optic neuritis. Similarly, now we may have tumors of the optic nerve sheath, which are very uncommon. Now, as I told you, idiopathic intracranial hypertension, the patients can present with progressive visual loss. So that is where something we probably have a role to play. And the most common causes are probably tumors. Now, these tumors could be confined to the orbit. It could be tumors cellular, supracellular. It could be tumors within the sphenoid sinus. Not necessarily tumors, even simple mucosals of the sphenoid sinus, when they expand, they erode the optic canal and can cause pressure symptoms. Thyroid orbitopathy, yes, Graves' disease is one cause. And then we have a whole range of patients who come in with traumatic optic neuropathy. So if you see, there's fairly a whole lot of pathology where an ENT surgeon probably has to be involved with a neurosurgeon to tackle these kind of cases. Now we'll start off with some surgical videos here. So are there any questions so far? Anything that you would like to ask? Am I too fast? Am I clear?
No, sir. It's really very good. No questions till now.
Okay, fine. So now just a short history of this patient. This was a patient, elderly, I would say around 60s, a lady in her 60s. She presented with, no, I haven't played the video. So elderly patient in her 60s with diabetes uncontrolled, presented with deterioration of vision. So she had severe pain around the eyes and deterioration of vision. We did an imaging and we could see that there was disease, I would say fungal sinusitis within confined to the sphenoid with erosion of the optic canal. So if you see this is an endoscopic picture, and you can see the pus here, that is actually the superior turbinate. There's some polypoidal tissue. This is the right nasal cavity. This is the middle turbinate. So we start off with a full house FES, conventional uncinectomy. So whenever you deal with pathologies of the sphenoid sinus, so that is a maxillary opening. So you can remove the uncinate. So whenever you deal with pathologies of the sphenoid sinus going on to cause optic nerve problems, it's important that you get a complete exposure of the entire sphenoid sinus. So you cannot take a midline approach or just access the sphenoid through the natural ostium. So do a conventional full house FES. I mean, you need not open up the frontal in this kind of cases if it is not involved. So open up the bulla, do a MMA, open up the bulla, clear off the disease, get a wide exposure, because at the end of the surgery, you want a very wide opening so that you can inspect this cavity from time to time in the postoperative period. And also, you have definite access as far as if at all you are planning to use topical medications. So now there is a bulla that is opened up. So this is the medial border of the bulla. So I have already traced the lamina here. And in this patient, actually the CT scans had shown a laminar erosion as well. So you can see the middle turbinate. Now once the bulla is taken off, is the picture clear?
Yes, sir. The picture is clear, sir.
Okay, so you can see this is the ground lamella. So you start creating a small window here, the superior meatal window. And then once this window is created, so the disease was predominantly confined to the posterior ethmoids and the sphenoid. So you can already see the inflamed mucosa or the edematous mucosa here in the sphenoethmoidal recess area. So start widening it, keep going progressively. So normally in these kind of infective pathologies, you encounter some amount of bleeding. So you can see the fungal element slowly coming into the picture. So keep widening, taking it up. So as I told you, from turbinate to the lamina and all the way to clear off or delineate the skull base. So at this point, now I'm being slightly gentle because I knew from the scans that there is a dehiscence of the lamina here. So you can see all the inflamed mucosa and you can see the fungal elements there. So this inflammatory mucosa generally tends to bleed. So the only way to stop it is to radically clear off the pathology. Once all the mucosa comes out, the bleeding usually tends to settle down. Because these are not patients whom you have adequate time to prepare like in your conventional endoscopic sinus surgery. It's more like a surgical emergency, I would say, when you have. So you can see the lamina here. The lamina was dehiscent. You can see the orbital periosteum fairly exposed there. Okay, so this is something that you need to look up on your scans. Now, this is a superior turbinate here. And for me, the best way to enter the sphenoid sinus would be to follow the lower half of the superior turbinate. Just take off the lower half of the superior turbinate. So this is a septum. You have all this edematous inflammatory mucosa surrounding this area, and just get in and you can see the fungal disease there. And then widen it all the way superior to the level of the skull base to the level of the orbital apex and midline to the level of the septum. Now, all these materials are cleaned off. So as I told you, we were expecting some bleeding. So you can see that there is fungal disease here in the lateral recess. So in the depth there was also, so I can already see the roof of the sphenoid. Now, in most of these kind of cases, you can see the fungal elements going down deep into the clival area as well. And in most of these cases, even if the optic nerve is well pneumatized, is very prominent, the edematous mucosa would actually cover up the entire optic nerve. So now this is just an angled view into that lateral recess, just to show it is not something probably relevant to the optic nerve. And then now we'll finally have a look at what happens to the optic nerve in this particular case. Now, if you see here, after all that inflammatory mucosa is just taken, you can see all this inflammatory tissue here, right at the orbital apex, and you actually get to see the inflamed optic nerve. Can you see this thickened nerve here? And all the bone around that is eroded. And this dimple here is the optico-carotid recess, the lateral optico-carotid recess, and that is the optic nerve. So normal optic nerve has a whitish color. Now, when you have this kind of, so this is actually optic neuritis. You can see it gets congested. The color changes. So all you need to do in this kind of situations is to remove the fungal pathology, decompress the nerve, and this was invasive fungus. So we started the patient on antifungals, voriconazole, and the patient did well for a few months. And after that, due to some, she had multiple issues. She was a transplantee, and due to some complications, I think 8 or 9 months down the lane, she succumbed to her renal issues. Now, another important condition that we would talk about is something called as a superior orbital fissure syndrome. So, as I had already mentioned about the structures passing through the superior orbital fissure. So, involvement of all the structures passing through the superior orbital fissure. So, these patients can present with diplopia. They can present with paralysis of the extraocular muscles, exophthalmostosis. And if the optic nerve gets involved along with this, then we term it as the orbital apex syndrome. So orbital apex syndrome can be very similar in presentation. So as I told you, the patients can have visual loss, proptosis, exophthalmos, restriction of eye movements, and so on. So this can be a presentation again with invasive fungal sinusitis. So this is one of our papers where we had a case of an orbital apex syndrome in a child, which was published way back in 2008. This was again secondary to a Aspergillus flavus infection. So where the patient also had cavernous sinus thrombosis. And again, this was a patient who did exceptionally well after clearance of the pathology surgically and with antifungal therapy. Now, I had already mentioned about the radiological aspects of benign intracranial hypertension. So these patients could present with features of raised intracranial pressure, headache, vomiting, and they can have progressive blurring of vision. And this is probably one condition where you can think of doing an optic nerve decompression when the patient has a progressive loss of vision. So if you go back to the earlier slides, when I told you that the optic nerve is surrounded by layers of the dura or the meninges. So it is surrounded by CSF. So when the CSF pressure builds up, this pressure gets transmitted and the nerve gets compressed. So if you can slit, so one indication to do a fenestration or a nerve slitting when you do optic nerve decompression would be a benign intracranial hypertension. So by making an incision on the sheath and letting out that CSF, you are relieving the pressure or the strangulation effect. So for me, I routinely do not do a decompression. I mean, do not do a fenestration in all the cases. We used to do that earlier, but then we found that it didn't help much. So for us, it's decompression in most of the cases, and in selected indications, we go for a fenestration. I would be coming back to that aspect a little later during the talk. Now coming to tumors, now isolated tumors of the optic nerve, yes, you have certain tumors like gliomas, meningiomas. Now meningiomas, as you know, they arise from the meninges. So there are specific locations. You can have planar meningiomas, tubercular meningiomas, olfactory groove meningiomas, and so on. Now this is just an example of a optic nerve sheath meningioma. So now this is an isolated entity, a very unusual case report. I mean, this is not my case. I had taken it from a journal. So where you can see this is a left nasal cavity. So this is a superior aspect, this is a lateral aspect. The optic nerve has been decompressed or exposed, I would say. The sheath is incised and you can actually see the meningioma here. And the sheath and the meningioma is resected. Now the controversies, so there are a lot of controversies regarding management of optic nerve sheath tumors, that is basically glioma or meningioma. Now the decision to intervene or to take up this patient for surgery would primarily depend on the visual status of the patient. If the patient has poor vision, you can afford to operate or surgically debulk these tumors. But if the patient's vision is good, then probably you may have to think of other options like radiation. So it is not the standard of care as far as tumors of the optic nerve sheath are involved, because at the end of the day, you cannot compromise vision for resecting a tumor in that area. So that is something that you need to keep in mind. Now, I would take
Sir, I have a question from Jankiram sir. So we have a patient in our ward. He has fungus which is sitting in the superior orbital fissure. It is causing optic neuritis. So sir is asking, what will you do?
So fungus sitting, you mean to say from the sphenoid sinus, and patient has inflammation, involvement of the superior orbital fissure.
Superior orbital fissure is involved.
So there is fungus in the sinus and the superior orbital fissure. How did you? So you have done some surgical procedure.
So we have sent for a biopsy now, and he's having intense pain.
So now
with loss of vision also.
With loss of vision.
Yes, sir.
Yeah. Now the thing is, it depends on your. Now is this patient immunocompromised?
No, sir.
Patient is not immunocompromised.
No, sir.
Okay. Now the thing is the duration of onset. Now how long is the visual loss? Is it recent sudden onset?
Yes, sir.
Yeah. So I think in this case now you have taken a biopsy. So biopsy is the first thing what you should look for. Now if the biopsy is inconclusive,
yes, sir.
then the next option would be to go ahead and decompress the patient, because now if it is a fungal infection, now if it's an invasive fungus, giving steroids would be a controversial entity, because it adds on to the progression. Now, the chances of invasive fungus, now, as you said, the patient is immunocompetent. Now, in immunocompetent, there is still a possibility of having invasive fungus. Now, the issue here is the role of steroids. Now, steroids, again, are controversial in invasive fungus. Now, if you have anything with rampant progression and if you are suspecting, then probably the option would be to decompress it.
Yes, sir.
I mean, what is Sir's thought about it? I would like to hear about it also.
Okay, sir. I'll let you know, sir. So we have another question from Dr. Desu Murali Krishna. He's asking, what are the safe drugs and the cost of antifungal treatment for invasive fungal sinus pathology?
Okay, I think that's a totally different topic, but then I would just brief you about it. Now, when you talk about invasive fungal sinusitis, the common organisms that we are talking about are predominantly the Aspergillus species and then probably the Mucor species, the Rhizopus. Now, when it comes to Aspergillus species, as of now, the first line of investigation, the first line of management would be voriconazole.
Yes.
Voriconazole. Now you can have refractory cases wherein you may have to consider using amphotericin. But if you are dealing with a mucor, then probably amphotericin is the first line of drug.
Jankiram,
Yeah.
Jankiram sir is saying, his question is, would you do a optic nerve surgery taking off the movements?
I didn't get your. Will I do optic nerve surgery to take off the? I didn't understand the question.
So the eye movements.
Okay.
Optic nerve surgery is needed in this case. Would you do?
For the eye movements.
No, sir.
Or the vision. No, you're talking about if the patient has restriction of eye movements, would I do any surgery to restore the eye movements?
Sir, is an eye with vision but no movements useful?
No.
I mean, if we do optic nerve surgery, taking off the movement of the eye, then even if we have vision in the eye, is it useful? Is it of any use? Should we do it?
No, obviously, the restriction of eye movements is a totally different issue. Now, obviously, these patients will have diplopia, but now the question here is, when you have restriction of the eye movement, that means probably, I mean, if the vision is intact, that means probably the optic nerve is not involved.
Yes, sir.
Yes. So when you're saying restriction of eye movements, that probably would amount to something called as a superior orbital fissure syndrome. So you have just restriction of the extraocular movement. So one of the options that you have is to decompress the superior orbital fissure. You can just de-roof the bone over the superior orbital fissure.
So there is mild restriction of eye movements with vision loss.
Why?
But he's having dull blurred vision. Diplopia is also there. But
so he's having blurred vision. So that means, okay, I thought the vision was normal and just restriction of eye movements.
So,
now you're saying his vision is blurred.
Also, and there is slight vision loss.
So that means it is probably a case of what I was talking about earlier, that is orbital apex syndrome. So you're probably talking about superior orbital fissure with apex involvement. So in that kind of situation, yes, again, now the surgery is not the sole treatment. As I told you, if it is a fungal pathology, you decompress. Now, if you got tissue for diagnosis, you decompress if it is deteriorating and continue with anti-fungal therapy. I mean, what is Sir's plan as far as this case is concerned? Because these are things that actually warrants discussion. So I would like to know what Sir's plan of management is.
So we are waiting for the biopsy report now, sir.
Okay, fine. So can I continue, or is there anything else?
No, continue, sir.
So I would just take time with traumatic optic neuropathy, because this is something that we focus on a lot. When you talk about traumatic optic neuropathy, the pathogenesis, it is a very complex mechanism. It's not just a nerve impinging, I mean, a bony spicule impinging on the nerve and causing blindness. So you have primary mechanisms, you have secondary mechanisms. So when you talk about primary mechanisms, you're talking about the shearing injury, that is compression forces being transmitted to the optic canal. So when you have a compression force getting transmitted, it can result in contusion of the intracanalicular optic nerve. So as I told you, that 1 centimeter of the optic nerve which runs through the bony canal. Now, if there is some sort of edema that sets in, what happens is the nerve gets strangulated and it leads to ischemia. It leads to edema and eventually ischemia. So it results in what we call as a compartment syndrome. So you have compartment syndromes in other parts of the body. So the same way you can have this. Now the secondary disturbances. Now what are the secondary things? So there's a lot of disturbances as far as the cellular homeostasis is concerned. So you can have ischemia and reperfusion injuries. There is release of bradykinin, which actually accelerates the edema of the optic canal. The release of calcium ions, which eventually leads to cell death because of release of metabolic toxins. And there are cell-mediated mechanisms which eventually lead to tissue damage and demyelination. So if you see, when a patient has an optic nerve injury, there are so many things that are happening. And unfortunately, with the present day diagnostic tools, we really are not able to go in depth as to assess what exactly is the status of the optic nerve post-injury. So that is one of the biggest drawbacks. Now, when you talk about facial nerve injury, you have tests like neuronography, you have tests like electromyography, which actually tells you if the nerve is regenerating, degenerating. So you have some idea of as to what is going on, and you have ample time in your hands. Now, whereas with the optic nerve, you really do not have much of time. So it's just a matter of hours within which the damage is usually done. Now, talking about classification, There are different types of classification, but then the most commonly used classification is the classification of direct and indirect. So when you talk about direct optic nerve injury, you're talking about a crush injury or a penetrating injury, and there is usually hemorrhage into the nerve. And indirect is basically when there is transmission of forces to the optic nerve, which leads to edema and ischemia. Again, based on the site of injury, you have different classifications. And again, based on fundus findings, you have different classifications. So as far as optic nerve injury is concerned, fundoscopy is of very much importance because it gives you so many details. Now, the clinical presentation fairly for following a road traffic accident or a fall, it could be a sudden, it is usually a sudden unilateral loss of vision. Bilateral visual loss is very, very rare. I mean, I have not seen one yet. And most of the times, these patients will have other associated major injuries. So an isolated optic nerve injury as such is uncommon because most of the times, the patient will have other craniocervical problems. The consciousness level of the patient is something, again, most of these patients would be intubated, would be unconscious, and may not be able to cooperate at the time when you assess or examine these patients. And what one needs to keep in mind is that even if the visual acuity is normal at the time of admission, there is a chance of a delayed visual loss in around 10% of the patients because of the slow onset of edema. Now, relative afferent pupillary defect, I did already emphasize on its importance. So this is something that can be done bedside. Now, if the patient is conscious, cooperative, color vision assessment can be done. Now, what one needs to remember is that there is no visual field defect, or on perimetry, there is no visual field defect which is pathognomic of optic nerve trauma. Now, as I told you, you could find any of these combinations. Now, fundoscopy, it is something which plays an important role. So you can have findings from papilledema which says that there is raised intracranial tension or if there is an optic nerve injury. Whereas if you have a finding of a ring-shaped hemorrhage adjacent to the optic nerve, it indicates that the patient has a partial or complete avulsion of the optic nerve. Now, if you have that finding, then there is no point in attempting anything either medically or surgically because this patient is not going to regain his vision. Remember, I told you optic nerve does not have the ability to regenerate. And again, the role of assessing intraocular pressure probably may be handy when you have a patient who has an orbital hematoma with a progressive visual loss. Now, the first line of management when we deal with optic nerve injuries would be medical. And again, there are a lot of debates when it comes to the medical line of management as to what exactly is the ideal dose of steroid to be given, which is the preferred steroid. Now, as far as the latest guidelines go, so this is in conjunction with, or this is in line with the National Acute Spinal Cord Injury Protocol. There is a study 2, which talks about mega dose of steroids. Now, mega dose of steroids, ideally preferred methylprednisolone. And the most important thing is to start methylprednisolone as early as possible. So they say the results would be better if you can identify, pick up optic nerve injury and initiate treatment within 8 hours of injury. However, the other side to this is now if the patient has other associated neurological problems, like maybe the patients will have a subarachnoid hemorrhage or a subdural hemorrhage, comatose patients, now you have risk of starting high dose steroids because the mortality rates are fairly on the higher side with high dose steroids in these set of patients. So again, you need to decide if you want to go with a mega dose steroid therapy, or would you like to stick on to your conventional 1 milligram prednisolone therapy. So it depends on the patient's general condition. So what it does is actually it causes stabilization of the microcirculation and the calcium homeostasis. So I told you earlier the importance of the homeostatic changes where there is influx of bradykinin, there is influx of calcium which leads to cell death and release of toxins and so on. So now surgery is always complementary to steroids. So now you have certain indications where you can outright take the patient for a surgery, but otherwise, when you're in doubt, always go for a trial of steroids. And then if it fails, that is when you take a call on surgery. And post-surgery, again, you have to continue these patients on steroids. So theoretically, what we believe is that it relieves the annular strangulation and reestablishes the nerve function. So what is the criteria for decompression? So when you talk about criteria for decompression, so this is actually the criteria that has been laid down by the International Optic Nerve Study Group. So where they say that at least 50% of the circumference of the osseous canal has to be removed. In other words, 180 degrees of the bony canal has to be decompressed. 2, removal of the bone along the entire length. So that is from the orbital apex. I did show you how the transition starts from the lamina, the orbital apex, till where the nerve starts to go intradurally. So decompress the entire length, unlike in facial nerve where you say decompress few millimeters anterior and few millimeters posteriorly to the site of the lesion. Here you will have to decompress along the entire length. And the third aspect is incision of the dural sheath along with the annulus of Zinc. Now this to me, I would say is a controversial topic. It remains a controversy. But however, we used to do this earlier and now we have moved away from this because we had patients, we had recovery with just simple decompression and we found we couldn't come out with a statistically significant difference or advantage with the nerve sheath incision. However, there are a couple of indications that I would like to mention where a nerve sheath incision is warranted. So one is a situation where I had mentioned before, that is idiopathic intracranial hypertension or benign intracranial hypertension or pseudotumor cerebri. The second situation would be when you have a nerve sheath hematoma. So the role of imaging again. So if you can pick up a nerve sheath hematoma, a hematoma within the nerve sheath, then obviously incise and release the hematoma. Now, what are the indications for decompressing? So if you have a radiologically evident bony fracture which is impinging on the optic nerve, that becomes an outright indication, provided the general condition of the patient permits you to take up this patient for surgery. Optic nerve sheath hematoma, as I had already mentioned. Now, if the vision is worse than 6/60, and if there is failure to improve or deterioration of vision after 48 hours of steroid therapy. Now, what happens in our situation, in our scenario, in the Indian scenario, if you see most of the times, the optic nerve injuries would not be picked up at the time of admission because this patient will have multiple other problems and all the attention goes into those areas. And it's only either when the patient comes out of the ICU and the patient becomes stable and when the patient himself says that I have loss of vision, we notice it, because generally we do not make it a protocol to evaluate the eye or just have a look at the pupillary reflex. So it is generally not documented, but now with increasing awareness, we make it a point to make sure that we assess the optic nerve in all patients admitted to the neuro ICU with multiple polytrauma, I would say. Now, I would just start off with a series of videos. Now, so some of these videos are very old now. As I say, this is probably one of my oldest collections. I would say around 10 years old. So the picture quality may not be all that good. As we go through, you will see the transition. And this video, some of them are edited very much. And I would like to actually take you through the real feel of the surgery. Because when you operate on a patient, now first and foremost, when you have a patient with a traumatic optic neuropathy, if you have this kind of a finding, a periorbital ecchymosis or what you call as a raccoon's eye appearance, and this is highly indicative of an anterior skull base fracture. So remember, traumatic optic neuropathy, when you take up these patients for optic nerve decompression, it is not like how you deal with a normal endoscopic sinus surgery. Expect anatomy to be distorted, expect all kinds of problems, and be prepared to face complications. So here, now this is a right nasal cavity. So you can see, so this is a very old picture. This is a single, I think a single chip recording. So we are doing a uncinectomy here. So as I told you, in these kind of cases, we generally prefer doing a full house FES. So now the problems here are because these patients are taken up in the acute phase. So generally immediately after trauma, maybe 24 hours, 48 hours. So there will be a lot of inflammation. The mucosa will be inflamed. You do not prepare these patients. Now here you can see that the maxillary sinus is opened up. You can see the contusion within the maxillary sinus. So if there are sometimes you'll have fractures running along the maxillary sinus. So you can see contusion around all those areas. Now this is actually looking up into the frontal recess area. So we are not actually opening up the frontal recess. Now go with a conventional bulla opening up the bulla. And most of these cases will have fractures associated with the posterior ethmoids as well. So if you see here, now this is the finding. Can you see here? You can see all the fractured bony spicules. So it's not like what you see normally. Multiple fractures, the lamina will be fractured, and with this you will find a lot of blood clots. So identify the lamina, look on the scan, see if there is any breach of the lamina. And secondly, in this case, so I was suspecting a skull base fracture as well. So gently use curettes to flake out all those bony spicules. If you use powered instrumentation, the problem here is, now if you see here in this case, you can see that the dura is already exposed. It is thinned out. It's something like a floating skull base. So multiple fractures all on the skull base, but luckily this patient did not have a CSF leak. But you have to anticipate, you have to be prepared. So perform a Valsalva, make sure there is no leak, because if there is a leak, always plug it on table. So if there is no leak, leave it there and then proceed. So you have to be careful when you use debriders along the skull base, especially in these cases with multiple fractures. Now, secondly, if you see in most of these patients, you'll find this kind of an yellowish discoloration along the lamina. Now, why this happens is because there will be hemosinus. So you can see the blood clots which I'm sucking out when I open up the sinus. This comes constantly in contact with the lamina, and the hemosiderin depositions actually gives that color, yellowish color. So here, once the sphenoid is opened, we are drilling off the optic tubercle portion. So you just saw me using the drill there. And secondly, as I told you, there will be severe mucosal edema. So you can see the fracture segments here already. There is a lot of bleeding. So there will be bleeding. You can't stop this bleeding by just simply packing. So you can see a fracture line here. It's already seen there. The next step is to strip the mucosa, because unless and until you remove this entire mucosa, you're not going to trace the entire course of the nerve. So be gentle in stripping. As I told you, there can be multiple fractures. Sometimes this can be attached to the dura as such. So gently peel it off, gently peel it off. Now, when we talk about optic nerve, always remember the internal carotid is in close association to the optic nerve, the skull base is in close association to the optic nerve. So now once this edematous or inflamed mucosa is removed, now you start seeing the fracture site little more better. So what you can do is you can actually clean up all the clots, give few washes. So you need to have a little more patience. So I put a patty there, and now what I've done is I've come back to the lamina. Now come back to the mid portion of the lamina and gently start decompressing. So I told you this is a very old video. This is around 10 years back. So gently start decompressing the lamina. So just keep lifting it up and make sure you don't come too anteriorly, because you don't want, and also try to keep the periorbita intact, because if fat collapses, it becomes difficult to proceed. And by coming too anteriorly, if at all you accidentally open up the periorbita, the fat collapses and tends to obscure the frontal as well. So mid portion is fairly enough. Now, once you start going posteriorly, at one point, the lamina fails to give way, in the sense you cannot lift it off. Now you see that it starts becoming very thick. So that thick ledge of bone is that optic tubercle. And then from there, I told you, the optic nerve starts taking off superiorly. So now we gently start taking off or elevating all that spicules. One of the important things with optic nerve decompression is that you may have to use your microsurgical instruments like the round knife, flag knife, and so on. And in this patient, now if you see, this is something which should be done with caution. I would say with absolute caution, because if you see, you can see the spicule on the nerve here, and this is the carotid. So I need to be prepared to deal with a carotid bleed if at all I have one. Now, secondly, when you manipulate pieces or spicules around the carotid, move it away from the carotid. Secondly, when you pull it out, make sure it is taken up vertically, and under visualization, you drag it out, because if it is placed horizontally and you pull it out, you would cut through the carotid. So the judicious use of instruments is something that I would like to emphasize on. You may have to use your micro ear instruments. Now you can see the nerve here, it's fairly white in color. So that means probably viable, probably something that I can salvage. And now here you can see what I'm touching is actually the exposed portion of the carotid. And luckily, no bleed in this case. So be prepared to deal with a CSF leak, be prepared to deal with a carotid injury. So these are things that you need to keep in mind before you venture in. And whenever you have an exposed skull base or a dura or an exposed carotid, always make it a point to cover it with a facial layer, because there is again a chance of a delayed onset CSF leak. Now, at this point, if I don't do anything, maybe a couple of days down the lane, I may get a call saying that the patient is having a CSF leak. So cover the skull base and never leave your carotid exposed. Now, here I would take you to, now you will have, I think that was the old set of videos. Probably now we get to the next set of videos here. Now, this is again another situation. This is the right side. So we have fairly completed the anterior ethmoidectomy. I'll just take you through the, so this is actually the bulla that is open and clots being sucked out. So this is a middle turbinate here. That is the level, the maxillary ostium. So that is a ground lamella here. So the medial wall of the bulla is being taken down. So the same procedure as what I had shown earlier. So this is what we follow standardly for all optic nerve injuries, nothing different, a full house fest. You can spare the frontal. So keep debriding all these tissues away and you'll find a lot of this kind of edema here. So identifying landmarks becomes slightly difficult. So identifying the port. So we are taking the medial approach to the sphenoid here. So that is a septum there. This is the posterior ethmoid. And just tracking our way into the sphenoid sinus. So as you go down, now here in this case, unlike the previous case, there is not much of fractures within the posterior ethmoids. So now we are gently opening up. So that is actually the sphenoid os area. So that is all covered with edematous tissue. So just fracturing that last wall there and to gain access into the sphenoid sinus. So now widen the sphenoid sinus. So you can use your punches. Now here I generally use the debride really to elevate this because most of the times it will be fractured, so you can easily lift it up. So now we have the area. So the orbital apex, the roof of the sphenoid. And as I told you, this mucosa will bleed. So this is real time. The reason why I didn't edit is just to show you how practically the difficulties that you would face in this kind of situation. So when you strip the mucosa, it bleeds. So as through each of these steps, it bleeds. So put a pack, wait, have patience, and then proceed. So same way, again, where it bleeds, move to a different side. Don't get stuck during the surgeries. Move to a different side. Continue with the elevation of the lamina. So I think the same thing what I had shown earlier. And then you can see the orbital periosteum. So now you can see once it is packed, you can see the contusion. So look out for these blood clots inside the sinus or in relation to the optic nerve. So if you see again, as I told you, the hemosiderin collection here around the cellar area, you can see the contusion around the dimple. So that is opticocarotid recess. This is the edematous optic nerve. This is a carotid bulge down here. And there is the cellar there. And this is actually the optic tubercle. So under that would be the fracture site. So now again start elevating so you can see the optic tubercle. Start elevating or stripping that mucosa from the sphenoid sinus. So these steps will bleed. Again, I emphasize these steps will bleed. So now once you start elevating it, you start seeing the bulge of the optic nerve. So you can see it is much more easier to appreciate the optic nerve rather than trying to visualize it through the mucosa. So you will have to always strip off. Now, it may not be necessary to take out the entire lining of the sphenoid sinus. So in this case, if you see I've just elevated this and then this debriding part of it, so retain the rest of the mucosa, so it mucosolizes in or heals much faster. So debride all that. And now you can see the fracture line here. So you can see the fracture spicule. So once the mucosa is removed, usually the bleeding settles down. So you can again see the fracture line here. So as I told you, again proceed to expose the orbital apex. Now this is drilling of the optic tubercle. So steps are more or less standard. Or expose, do the sphenoid, or widen the sphenoid sinus, drill out the tubercle, deroof the lamina. Now you have thinned out the tubercle and then I'm just elevating it. So normally you cannot elevate it very freely because this bone is usually thick. And then once that ledge of bone is removed, you can actually follow. So these are just a couple of videos just to show you the entire surgery, how it goes through. And now with the suction elevator, I'm gently elevating the bone over the optic nerve. And this is continued all the way posteriorly. And now you can see. So this is actually the lamina, the orbital periosteum. Lamina has been removed, the periorbita, the orbital apex, and you can see how the nerve goes down all the way into the bone. So this is where it actually ends or it exits. And even in this patient, you can see, now this is a lateral opticocarotid recess. And as I told you, if you can just draw a line through the upper portion and the lower portion of the lateral opticocarotid recess, now this is the clinoidal segment. So in this patient, you can see small multiple fractures on the carotid. and that is the exposed clinoidal segment of the carotid. So remove all these bony spicules because any free-lying bony bits can give rise to a chance of osteomyelitis in the post-operative period. So make sure you don't leave anything bony there. 360, I mean a 180-degree decompression along and also along the entire length with an exposed carotid. So you can actually place a small mucosal graft just to protect the carotid. Now this is a case which we did quite recently. Now here this is a young boy. So now the previous two cases that I showed you were patients who had remarkable recovery of vision. I would say now in optic nerve injuries or traumatic optic neuropathy is something where you can't guarantee any kind of recovery. So this is something where you have to take a chance. And if you see here, now here in this scan, if you see this is an ONOD situation. So you can see that's a sphenoid sinus. You have a small cell here and you can see this fracture in the region of the optic nerve. So here, the same way I've just completed my uncinectomy, I've opened up the maxillary ostium. Now we are going in through the bulla. If you see the entire lamina is kind of fractured. So you can see as we debride the whole lamina bone kind of wobbles. So if you see here, now that is the bulla being opened up. So can you see this? The whole lamina portion actually kind of wobbles with the debrider. Now here we get a view of the lamina. You can see that hemosiderin pigmentation. Now my aim is to get, now this is an ONOD situation. You can see there is a whole lot of fracture here, all bony spicules. So the safest option for me would be to enter in the sphenoid sinus at the inferior most portion. So be it an ONOD situation, be it a normal sphenoid sinus, try to identify the opening of the sphenoid inferiorly. So identify that and then I'll have to work out. So I am just trying to delineate the apex anatomy. Now drilling out the orbital apex, there is some thick bone around this area. So in these kind of situations, I generally resort to a single-handed drilling. Whereas in other cases, I'll tell you where we use the 400 technique. And here, this is the cell, and this is the sphenoid sinus below. So you can see the ONOD cell in relation to the orbital apex here. So now open up this cell. So as per the scans, within this we were able to see. So now this is a cell here. So that is basically the posterior ethmoid. And you can see just lateral to that cell, this is the area where we were seeing the fracture lines. So now come out, delineate the lamina, gently keep elevating the lamina, maintain the orbital, the periosteum intact. Now if you see, you can see multiple bony fractures here. And if you see here, this is optic nerve that is taking off from the orbital apex. So this area is probably the region of the fibrous annulus here. And this is optic nerve. And now if you see here, right on top, you can see the impingement here. There's a spicule that is going right into the optic nerve. So I'm just using a small sickle knife, but this is a blunt one, which I've been using for years. So it is safe. Don't use pointed instruments. So gently move that and you can see the impinged spicule being taken off from the optic nerve. Now, when you have this kind of a scenario, fairly the results are guarded. Or this patient, when we took him up, he had just perception of light. That was the only reason why we took him up. And you can see there is still a fracture segment which is sitting on the optic nerve, and there is a bone which is impinging on the optic nerve. So we decompress this whole segment, and in spite of this decompression, which I think this was taken up almost after 72 hours. So we're just thinning out that small bit of bone. So take care when you drill around the optic nerve that the optic nerve does not come in, the burr does not come in contact with the optic nerve. So gentle at slow speed, just polish that bit of bone, because if I try removing that bone, the whole skull base just comes out. So you can see we have drilled out all above. We have decompressed. Now this is the carotid there. This is the optico-carotid recess, and you can see the entire optic nerve. However, the surgery went on well. Things look beautiful, but the outcomes nil. So this is what can happen with optic nerve injuries. So you need to intervene at the earliest. Now the situations. Now what is important is from the scans you will not be able to predict. Now here, if you see in the earlier cases, there was no impingement of bony spicule on the optic nerve. Here, what you classically saw was an impingement. So when there is impingement, the fibers get damaged, and the chances of getting a satisfactory recovery is less. Now this is another situation. Now here already we have completed the ethmoidal dissection. So if you see, the entire lamina is fractured. This is a left nasal cavity for your orientation. The entire lamina is fractured. Now this case I had taken up on the I think this was taken up on the second day because the neurosurgeons were simultaneously doing a neurosurgical procedure. Sometimes you get lucky to get these patients on the very same day. So at the time of taking up, there was nothing. It was just an optic nerve injury. Now, if you see here on table, we have just gone in. And as I was proceeding to my dissection, now this is the posterior ethmoidal artery. This is the orbital periosteum, part of the lamina here. So if this is the posterior ethmoidal artery, this roughly corresponds to the level of the anterior wall of the sphenoid sinus. Now, this is the problem with traumatic cases. So you really cannot make out normal anatomy. And as I was dissecting, you can already see gush of clear fluid. So here, the patient has a CSF leak already. So now I am prepared to deal with the CSF leak. Now, what exactly is the anatomy of the sphenoid sinus? I'm not too sure. So I can see some bony spicules here. So I gently start teasing it out. Now, always remember, never pull out anything at the skull base. Now, I really don't know what this is attached to. It could be attached to the carotid. It could be attached to the optic nerve. It could be attached to the dura. So gently teasing it out. Now, this is probably one of the best cases in my collection. And I keep showing this case wherever I go. So now if you see here inferior, slowly start dissecting out all those mucosa. Now this is just a real-time video. So what we are doing is spending time gradually teasing out all those, elevating those spicules. So I am sure that this is not a bony spicule which is attached laterally, so hopefully not. Now here if you see superiorly, there is something white that is pulsating, that is the dura. There is something that is slightly discolored that is bulging inferiorly. So I know that is not the dura because it's coming from the floor. So I just make a small nick, and when I suck, when I just make a small nick and just open into it, just to see what it is, you can see clots coming out. So that is actually the mucosal lining of the sphenoid sinus, which is filled with blood. So now I have two landmarks. I have my orbital, the periorbita here. I have seen the dura superiorly and I am working inferiorly. So I'm staying within safe zones and trying to find my way and trying to identify the optic nerve. Now what has happened in this case is that the entire anterior wall of the sphenoid has gone into the sphenoid sinus. Now if you see, you can see the pulsations of the dura and there's a defect right here on top. And there's a large spicule of bone here which I'm just taking off. So I'm still not seeing the optic nerve. Okay. So I'm just taking out this large bony spicule of bone. Now the advantage in this case of having a CSF leak is that it keeps your field clear. So now you can see that is the optic nerve that is coming in the picture. Now you see the next spicule of bone. So gently start taking out one by one. So you can count the number of bony spicules that you'll be removing from this case. And you see how big these bone bits are. So as I told you, as you manipulate these bony spicules, you have to be very careful. So these could be attached to the carotid. So now I have put a pack in there and continue with the rest of the decompression of the lamina. So once the lamina is elevated fully, now you can actually see so all those fractured bits of lamina can be taken off. They serve no purpose. And now if you see here, you can see the whole view of the optic nerve, which goes on to pierce the dura. So can you appreciate that? So that is a whole, that is a dura. There is a defect in the dura superiorly. That is where the optic nerve goes on. So you have a complete decompression. So we had to deal with this as well. So put in a fat plug and then a simple fascia graft on top to cover. And remember, when you do an optic nerve decompression, always avoid a nasal pack because you have decompressed nerve. So preferably if you're placing a pack, you could place it somewhere in the anterior part of the nasal cavity, but not anywhere inside or in contact with the optic nerve. You really do not want to reapply any sort of pressure. So even when you do a CSF leak in these kind of cases, just put the fascia, apply gel form and keep it in place and come out. And this was a patient who had a remarkable recovery vision. So if you see here, the optic nerve sheath is intact. So what I'm trying to tell you is when you have a nerve sheath that is penetrated or impinged upon, the recovery chances keeps coming down. And just for completion, I would just show you one video on fenestration. So you can see here, this is the annulus of Sim. This is a lamina, this is the left side. So once the nerve is exposed, so you make your incision in the medial aspect. So the rule is you stay between the 12 and 3 o'clock position on the left side. And on the right, you could stay between the 9 and the 12. So you can see that this is the sheath and that is a nerve within the sheath. So we have moved away from this. I had already told you. So for us, indications are limited. So what is the latest guidelines? So if you see, the International Optic Nerve Study Trauma Group has come to this conclusion that sufficient evidence to conclude that neither corticosteroids nor optic canal surgery should be considered the standard of care. So you cannot say that I treat all my patients with steroids, or you can't say that I take up all my patients for optic nerve decompression. So it is appropriate to make individualized treatment decisions for a particular patient. So I did lay down the indications and how you go about selecting a patient. And what one needs to keep in mind is transection or infarction at the time of injury results in permanent damage. So if you have an optic nerve avulsion or if you have an optic nerve transection, no matter what you do, the patient is not going to have a recovery of his vision. Neural dysfunction secondary to nerve compression may respond to medical or surgical intervention. Yes. And now what is new as far as optic nerve decompression is concerned? Now this is one of the not very new study, I would say. This is actually a cadaveric study where they're talking about a supraorbital approach. So here now the thing is you place a brow incision, or elevate the subcutaneous tissue, remove the bony window, expose the dura, elevate the dura, and basically approach the optic nerve from top. So what you do is, now this is the optic nerve canal, you drill off the optic nerve canal and you can see the ophthalmic artery lateral to it. So they are talking about the decompression 180 degree from the superior aspect. Obviously the question would be, now will all cases of traumatic optic neuropathy. So if you see now the cases that I've shown you are specifically cases where the fracture line is on the medial aspect or where you can decompress it from the medial aspect. Now what if you have a bony spicule impinging on the lateral aspect? You probably may not be able to access it endoscopically. So in those kind of cases where you can actually gain access even from the superior and to the lateral aspect, but not very much to the medial aspect, this is something that has been advocated. But then if you see, by far the most common site where the optic nerve gets fractured is usually along the medial aspect. So this is just something new as far as optic nerve injury is concerned. Now going to the next set of, so it's all about optic nerve, right? So when you talk about optic nerve, you obviously can't skip expanded endonasal approaches. And the reason why this has become popular is because of increased illumination, magnification, improved cosmesis, and obviously the four-handed technique, which has been widely being propagated. And I would say, I frankly speaking, I learned my four-handed technique from Nishit sir and from Janki Ram sir. So I have to thank them for all the support and for all the help extended to me. So it's fairly a beautiful technique. Now we'll just go through a couple of scenarios here. Okay. Now, sorry. Okay. Now this is a case. Now I was talking about optic nerve. I was talking about expanded endonasal approaches. Something which probably I would have skipped out was a simple sphenoidotomy. I think this is what everyone should know. And many a times when I go to conferences or when we meet, I would say, when I would have done this during my earlier days, when youngsters talk, when they chat in a group, the first question is, have you started doing FES? Yes, I've started doing FES. I can confidently open up the maxillary and ethmoid, but I'm still not too comfortable with the sphenoid. This is the first thing. I'm not confident about the frontal. Now, why the sphenoid? Because of the fear that, you are bound to injure the carotid or the optic. And let me tell you, this is something kind of a pseudo fear, I would say. See, the thing is, there is no important structure that actually comes in the anterior wall of the sphenoid sinus. There is no important structure that comes in the anterior wall of the sphenoid sinus. So by far, if you see the straight or the simplest or the straightforward approach to, if you ask me the simplest or the most easiest sinus to approach should be the sphenoid, because if you just stick on to your septum, and if you can just go straight along the septum, you should enter the sphenoid sinus. There is no carotid, there is no optic. So one needs to understand the concept of sphenoidotomy. So for that, I would just show you this small video here. So this is a right nasal cavity. So in fact, this is actually done as a part of an extended procedure. So I've just edited a small portion of it. So we have already gone into the posterior ethmoid. So I've shown you enough of anterior and posterior ethmoidal dissection. So what you're seeing here is part of the superior turbinate. So we are past the ground lamella and we are working in the posterior ethmoids in the right nasal cavity. Okay. So you are delineating the, is the video clear? Yeah.
Yes,
Okay.
sir, the video is clear.
Okay. So now this is a superior turbinate. So this is a septum. So as I keep telling, to me, the best landmark is to follow the superior turbinate. Just keep trimming the superior turbinate. It leads you to the anterior face of the sphenoid. Okay. So you can see the sphenoid ostium, and then you can widen it superiorly. You can widen it laterally. Stay away from widening it inferiorly because the chance of bleeding would be much more. Now here, if you see, so you can widen it superiorly, widen it laterally to the orbital apex. So that is a maximum exposure that you can get. Now, if you want to, if you're doing an expanded procedure, then you can go for the inferior widening, but usually you encounter bleeding there. But other than that, for routine endoscopic sinus surgery, this would be more than enough. And once you do that, you see where the optic nerve is and where the carotid is. It comes in the far lateral and superior quadrant. So if you stay inferior, if you stay medially, there is no way that you would hit any of these structures. And here, the other thing I wanted to show you is, can you see how prominent this optic nerve is? So
Yes.
here you have a very classical supra-optic pneumatization. So if you see there is pneumatization above the optic, and you have more than 50% of the optic nerve jutting into the sphenoid sinus. You can see the dimple of the lateral optico-carotid recess, and you can see the carotid bulge. And this is the cella. And this is the roof of the sphenoid sinus. So follow the superior turbinate. It takes you right onto the anterior face of the sphenoid, identify the sphenoid ostium, and then keep widening it laterally and superior. And medially, the septum would be a limit. So that is how you would stay away from injuring the optic. Now going to the next slide, now we talk about the onodi situation. So I showed you onodi in a pathological scenario where we had a fracture within an onodi. Next common fear is damaging the optic nerve in an onodi situation. So when you say onodi, again, lights flash. You stop for a second. So now here, if you see here, now I will just show you this video. This is the same patient, the previous case. So if you see, you can see that optic nerve, the carotid bulge, the optico-carotid and supraorbital pneumatization. The posterior septectomy has been done. So by definition, an onodi is a horizontal or it can be an oblique partition. Okay, so can you see how this runs down like this? So it divides the upper part becomes the posterior ethmoid and the lower part is actually the sphenoid sinus. So this is a pneumatization of the posterior ethmoid above the sphenoid sinus. And you can see the relationship of the optic nerve in relation to the posterior ethmoid. So this actually forms what we discussed earlier on radiology, the type 4 of Delano's classification. Okay, now, but this is done for some other pathology, so I'll take you through this. So you can see that there is a view of both the sphenoids. So this is actually the sphenoid and this will actually be the posterior ethmoidal pneumatization. So you can see, so you can take out this onodi partition. And another important thing is when you have these intersphenoidal septations, the intersphenoidal septations have a liking for the optic nerve. So it has more of a liking towards the carotid artery, where in around 40% of the cases it gets attached to the carotid. And in approximately around 7% of the cases, the intersphenoid septum can go and attach to the optic nerve. So you got to be careful not to pull the partitions, rather use a true biting or a true cut forceps or gently drill down the partitions, because if it is attached to the carotid, you could probably end up avulsing the carotid. Okay, so hope that onodi concept and how you enter the sphenoid is clear. Okay, now we go still for more expanded procedures. So now this is actually a case of pituitary tumor. Now just to orient you, so we have done a posterior septectomy, bilateral sphenoidotomy has been done. Now if you see, this is actually the intersphenoid septation in the midline. Okay, and this is a patty that is placed down there. Okay, okay. So now you can see this is the right side. So you can see the optico-carotid recess. This is the optic nerve, the cellular bulge. So we are drilling out the partition. So you can see the optic on this side, the optico-carotid recess, the carotid bulge. So this is actually a fairly, I would say, beginner's delight, because you have a tumor which is protruding through the cella with well pneumatized landmarks. You can see your optic nerves very prominently, the carotids prominently, the optico-carotid recess. So remove as much of bone as possible. Place your incisions, U-shaped incisions. Gently elevate the dural flap. So with this wide exposure, so if you can go very close to the carotid, if you can take it up all the way till the tuberculum, fairly, your exposure is complete. So you feel happy when you see these kind of landmarks in a pituitary surgery, but this is not the day-to-day situation. So again, the role of irrigation in these kind of cases to achieve hemostasis, biopsy, and then how you actually proceed with a two-handed suction technique, starting inferiorly. So this is a routine pituitary surgery. So again, pituitary surgery is something probably the most common amongst us, the skull, one of the most common skull-based surgeries we perform. So start inferior, start going laterally, and then these are certain tips, the tips that we talk about, the Q-tip techniques. So you can see that finally that's a diaphragm that is descending down, and fairly we have a complete clearance of tumor here, and there is still some remnant of tumor here in this portion, and that can actually be, that also can be sucked out, and then you can fairly see how the diaphragm is uniformly descending, and there is a complete clearance of the tumor. You can actually visualize the cavernous walls here. So you can see the relationship of the optic superiorly. So this is a cavernous here. So by taking out all that bone as close to the optics and the carotids, you get ample space to work in rather than making these keyholes and trying to, you know, cure it out or trying to suck the tumor. Now again, the emphasis on exposure. Now you have a supracellular extension like this, where you have predominantly vertical tumors. I was talking about the snowman configuration or the figure of 8 configuration. So this is what we are talking about. So here in this case, if you see, we have done the bilateral sphenoidotomy. So it's not a very prominent optic nerve, not a very prominent optico-carotid recess. Okay, so you can see the intersphenoid septation, you can see the clivus. So again, we talk about the four-handed technique. So start drilling off the sphenoid septations, start drilling off the floor of the sinus. So drill out the septations, get it flush to the level of the cella. And here, because of the supracellular extension, we are going above the level of the optic nerve. So remember, now optic nerve also forms boundaries for transplanum exposure. So when you say transplanum, you work from the posterior ethmoids to the posterior limit would be the optic nerve. So if you see here, now this is optic nerve, this is the optic nerve. So you can see the area that we have exposed here already with the drill. The area between the optic nerve is basically the tubercular strut. Okay, and you can see the dimples here, the dimples of the lateral optico-carotid recess. So continue with your drilling. Now, when you drill along the optic nerve, drill parallel to the optic nerve. When you drill along the carotid, drill along the contour or curvature of the carotid. So these are all basic principles that one needs to talk about when you do skull-based surgery. So on either side, so you can see how the optic nerve, the strut, this is the planum that is exposed, and we are thinning down all, and then gently flake it off. So we generally stay away from using punches. So that is what I have learned from my teachers. And I think even Dr. Janki Ram and my boss, Dr. Nishit, also keeps emphasizing on the same thing. So you can see once it's eggshell thin, you can gently just flake off the whole bone over the cella. So remember, in this case, we had a massive vertical extension. So something that I had already mentioned, the MOCR. So the confluence where the carotid, the optic, the tubercular strut, and the cella, all this comes together at this point. So this is actually the medial optico-carotid recess. So you can see how far laterally we go close to the carotid, gently elevating. So if you see now, this is actually the area where we're coming to the medial optico-carotid recess. And now here, we're just drilling the tubercular strut, even in the medial aspects. So that is again thinning out the bone over the medial optico-carotid recess. And you can see this thinnish white structure here, which is the superior intercavernous sinus. So boundaries, so as a landmark optic nerve, now we are talking about optic nerve defining boundaries. So you can see the superior intercavernous sinus, you can see that the optico-carotid recess has been fairly drilled out here. Now we proceed with the dural incisions the same way as I showed in the previous video. And then I'll just show you. So once the dura is incised, yeah, the flaps are elevated, and then we start our dissection with the two-handed suction technique, staying inferiorly, superior, then going laterally, and then finally the superior most aspect of the tumor. So the advantage of this bone removal is that you can actually reflect the entire dura and work rather than trying to peep through a small opening. So you can see how much of elevation you get. So all that supracellular component, if you see, has come out because of this adequate bone exposure. So you can see that is a whole diaphragm that is descending. There's a normal pituitary gland here. That's a cotinoid which is used to push up the descended diaphragm. And finally, you can see at the end of the procedure, we managed to complete tumor removal, even for this vertically extending tumor. So the emphasis on removing the medial opticocarotid recess. At the end of the procedure, you can see how the entire diaphragm has completely descended down. Now, this is another case where the patient had a visual field defect. Now, if you see here, you can see here there's a lesion here. Now, this is a pituitary stalk which is pushed to the left side, and this is a pituitary gland which is inferiorly. So the lesion is above the pituitary gland. So this is actually a case of a rat case cleft cyst. Now, this is the exposure that we got. So I would not take you through the entire exposure. So this is after completing the middle turbinate resection, the MMA anterior ethmoidectomy. So we are right on the anterior face of the sphenoid. So this is a superior turbinate. So we'll join this surgery after we have taken off, we have done the sphenoidotomy. So the sella is exposed. So remember, as per the scans, we saw that the pituitary gland is inferior and the cyst is sitting superiorly. And this patient has a normal pituitary function. So it is important to preserve the pituitary function. So in other words, the tumor is impinging on the optic chiasm and it is supracellular. So same way, after thinning out, we start flaking off. So the techniques are again the same. So the entire sella is exposed. So gently exposing all this. So you can see the prominence of the optic here, the opticocarotid recess, similarly the opticocarotid recess. So fairly favorable situations when you start off your dissection. To gently flake off. So this is actually the Cortils elevator that we are using. And this is something which I would say Jankiram sir had gifted me many years back when he came for a workshop. So that is something which I treasure and keep it close to my heart. So you can see we can use the punches just to flake off, not really punch it. And then finally we use the carotid Doppler to ascertain the position of the carotids. Okay. And now I'll just give you a close-up view here. If you see, can you see something yellowish here? And you can see something whitish here. So we know that this probably is the whole cyst that is sitting there. So we just come slightly below that level, make a small incision, because if I make a deep incision, it goes all the way to the cyst. So, I mean, it is generally very difficult to get a cyst out in toto. So we'll just see how far it goes. So make a small incision and then separate the layers, just like how you do in your conventional pituitary surgery. So the endosteal layer you have this supplying. So this is again the Kassam's rotatable scissors that we are using here. So gently cut through, make sure you don't go too deep. And then, so just cutting through the layers gently. And then lifting it up. So same way, the U-shaped flap. So that is what we usually follow. We have actually given up on the conventional cruciate incision that was advocated long time back. So now, here in this case, now why I'm showing you this case is, as I told you, this cyst is compressing on the optic chiasm. So then just elevate the dural layer. And once the dural layer is elevated, now you can actually see the cyst here. Now this yellowish color is the cyst. Now as per the scan, the pituitary gland was pushed to the left side. So I start looking for the normal pituitary gland here. So now, if you just follow me, you can see the color of the gland here. Can you appreciate that gland there? It is slightly different color from what this whole thing is.
Yes.
So that probably should be the normal pituitary gland. And on this cyst, there was another layer. So I just made another incision and then just reflected that layer, and then I could expose the entire cyst. So can you see this here? So here you have a lesion which is going supracellular, so and going subchiasmatic. So basically pushing up the chiasm. Now, so that is a whole cyst that is protruding out. Now to dissect this, I think till this point I had luck, and beyond that the cyst ruptured. And once the cyst ruptures, what you do is just wait gently. Don't do anything. Don't apply suction. All you can do is just keep the suction there. Wait for the contents to come out. And you can ask your anesthetist to perform a Valsalva. So what you do is when Valsalva is performed, the intracranial pressure raises and you can see automatically all the contents get pushed out. You just keep waiting, waiting, and finally the contents get pushed out. And along with that, you can even see CSF fluid coming out. Okay. And what happens is that once the contents come out, you can see that the cyst wall kind of collapses. So can you see this opening coming up there?
Yes,
So
sir.
the cyst wall has kind of collapsed. And now once the cyst wall has collapsed, what I can do is gently get hold of the cyst wall and follow it up with gentle traction. So don't pull, as I tell you, don't pull, with gentle traction. Hold it with one hand, hold it to the forceps, gently reflect, release, reflect, release, and then finally with microsurgical techniques, you can just cut out the entire sac. Okay, so you can see how we gently peel it out. So take your time. So these are probably steps that we spend more time on. And now finally cut off that entire cyst wall. So this is sent for histopathology. Okay. And now you can see with an angle scope, that is a pituitary gland, the normal pituitary gland, and I'm going inside. And if you see here, you can see the arachnoid, you can see the optic nerve there. And this blood-stained area is the region of the pituitary stalk. And one more interesting finding, so there is a gush of CSF, so the whole wall has come out. And if you see here, you can see the optic nerve. So this is actually the level of the optic chiasm. And onto the right side of the screen, if you see, you will actually see the atherosclerotic plaque within the carotid artery, the yellowish plaques within the carotid artery. Can you see that? The yellowish plaque here. So that is atherosclerosis within the carotid. So finally, we could manage a complete excision, pack this with a dumbbell technique, and then apply your Hadad on top. And this patient has been on follow-up with a complete recovery of, her vision. Now, certain uncommon scenarios. Now, you can have distorted anatomies, anatomy in the sense pathologies that distort anatomy. Now, for example, craniopharyngiomas, patients with craniopharyngiomas tend to have poorly pneumatized sphenoid sinus. So the bone tends to be rock hard. Now you can have even fibro-osseous lesions of the sphenoid sinus which can compress on the optic nerve. Now this is one situation. Now if you see here, now this is actually a very old video. This is done single-handed. Now if you see, there is absolutely no landmark. So it's just nothing, no ridges, just hard, dense bone. So in these kind of situations, what we do is we just generally tend to thin down the bone. And this was before I had navigation. So you can see here, I've delineated the optic nerve here. Can you see that optic nerve? So roughly thinned out, delineated the optic nerve. The same thing we kind of identified on this side. And then went in the center. Had it been now, we would have probably been even more aggressive, going around removing more of the bone, trying to expose the carotid. So the thing is, it's obviously a learning curve where you start working, where you learn with each case. So you can see the classical greasy oil consistency of the craniopharyngioma. So where we had to decompress this actually, because it's more of a cystic lesion. Now here, if you see, this is another solid craniopharyngioma, predominantly solid, extending into the floor of the third ventricle. So I'll just quickly take you through this. So this is actually the view of the sphenoid sinus here. Bilateral sphenoidotomy has been done. So it's a very small sphenoid sinus. You have an optico-carotid recess there. So these are the partitions. So start off with drilling all the partitions down. So the optic chiasm, if you see the posterior part of the optic chiasm, is actually related to the anterior wall as well as the floor of the third ventricle. So if you go behind the optic chiasm, that is where you'll actually see that. So in this case, that is what you'll see. So you can see, as I told you, the discrepancy or the asymmetry of the optico-carotid recess on both sides. So now this is actually a massive supracellular extension. So we are doing a transplanum transtuberculum. So if you see, we are drilling out all these areas, as I had already mentioned earlier. So above the optic nerve till the level of the posterior ethmoidal artery, all this bone is removed. The tuberculum bone will be removed. So that is between the optic nerve, and also over the sella bone will be removed. And then we go for the pathology. So I will just quickly take you. So once you see the bone is removed in the midline, over all these areas. So now we can make your dural incisions. Now these dural incisions are continued even downwards. So it's something like an I-shaped incision. So you can see the dural incision is extended downwards. And once the dural incisions are completed, what we do is now we get a view of this tumor. So this hard thing is the tumor. And what we have right in front of us is actually the optic chiasm. So if you see here, this flattened structure is the optic chiasm. This is a carotid. And you can see this tumor going right behind the optic chiasm up into the ventricle. So now this was a time when we are using the two-handed technique. Ideally, the option would be to go with a microsurgical resection principle. These are basically controlled suctions where we have control on our food. So you can see how this tumor is being delineated from the surrounding neurovascular structure. So you can see the vessels here, and also slowly you will actually get to see the third cranial nerve coming in. So you can see the carotid, you can see the optic chiasm. So this actually tends to be slightly bloody at this point. So this is not the conventional suction, this is gentle suction. So you gently reflect, and you can see now with the suction we are gently dissecting the tumor out from the third nerve, which you'll get to see there now. So that's the third nerve. So you can see the neurovascular bundle here. And then finally, the same thing we complete on the other side, and the whole tumor was removed and blocked. So now it's not necessary to remove this tumor and block. So you can see the whole tumor. So now that is a basilar artery. These are the mammillary bodies. This is the third nerve, the PCA. Finally, the foramen of Monroe. So you can see where we are going behind the optic chiasm, and we get a view of all these areas. And finally, just to touch upon a few other areas, that is transcranial approaches. So again, you have external approaches.
So can I interrupt you for a minute, sir?
Yeah.
So Janakam sir was asking a question. Incidence of diabetes insipidus in your post-op cases, sir?
So, so we do encounter transient diabetes insipidus, I would say, fairly very commonly, especially in pituitary cases, irrespective of very gentle handling. But most of the cases have been transient. If I recollect, I would say it's just, I think, 2 patients who had diabetes insipidus which didn't recur post-op. I mean, in the sense which went on to become permanent. But so it is actually taken care of by our endocrinology team. So we have a neurosurgeon and endocrinologist. So they usually look after it. But then transient insipidus is fairly common, I would say.
Okay. Thank you, sir.
Yeah. So just to touch upon orbitocranial complications, I mean, the approaches. Now you have the classical orbitocranial approaches, the pterional approaches, and the frontotemporal orbitozygomatic approaches. So now, other than that, there are a lot of approaches in literature, the supraorbital, transorbital. There are literature supporting lateral orbital wall decompressions when you have a fracture on the lateral aspect, the transcaruncular, the transethmoidal approaches, and so on. But if you just concise or simplify, the external approaches of optic nerve would more or less be just 3 simple approaches, 3 or 4 simple approaches, I would say. One is a transcranial supraorbital approach. Now here, it is something similar to your bicoronal, where you place your bicoronal incision, elevate the skin flaps, and you take a window of bone. And it gives you an exposure of the frontal dura, the orbit. So you can access tumors extending intracranially, tumors into the orbital apex, and also the medial orbital compartment. The other approach is a lateral microsurgical approach, where you perform a lateral osteotomy. So you go from the lateral canthus, place an incision, and take a window of bone, so that gives you direct access into the lateral compartment. And then you have a medial microorbitotomy. So medial microorbitotomy is again reserved for tumors which are confined to the medial intraconal compartment, and preferably in the anterior 2/3, because you do not get a very good access with the posterior extent of the tumors. So when it comes to selecting a choice of approach for orbital tumors, again, optic nerve is the decision maker. Why? Because the approach depends on the location of the tumor in relation to the optic nerve. So the size of the tumor, the vascularity of the tumor, the probable pathology anticipated, and one needs to take into consideration the visual status of the patient. So we have to, by all means, avoid surgical manipulation of the optic nerve. Now, this is probably one of a very interesting article that I came across. This is basically the round-the-clock concept by the Pittsburgh group. So if you see right here in the center, this is the optic nerve, right here. So now if you have, now this is a right orbit. So if you have any pathology from this 1 to 6, so that is predominantly in the superior as well as involving the entire lateral quadrant, then your approach should predominantly be external, because you do not have any role for an endoscopic approach. So your approach would be a frontotemporal craniotomy if it is confined to any of these areas. Now, if you want an inferior access, you can combine with the orbitozygomatic osteotomy, so you can access it inferiorly as well. The second scenario, if the tumor is confined just to the lateral aspect, you could go with a lateral orbitotomy. So you could just make 2 cuts here and remove this piece of bone and get a direct access to this tumor. Now, in the medial compartment, so anything in between the 1 to 6 o'clock position, again on the right side, in the anterior aspect, your option would be a medial microorbitotomy. We are talking about intracorneal tumors. And the endoscopic endonasal approach is anything posteriorly. Okay, so basically between the 1 and the 7 o'clock position. So again, if you see, optic nerve, to me, is a very important landmark, not only when it comes to routine endoscopic sinus surgery. You see it even in skull-based surgery. You talk about it defining boundaries of your approaches. You see optic nerve as a decision maker. Okay, so if you see, these are the different things that you actually think of. So this is in nutshell about the round-the-clock concept. So you can actually go back and look up about this paper. This is from the University of Pittsburgh. So where they have beautifully described this approach. So to conclude, I think over the past 2 hours, it was all about optic nerve. So when you talk about optic nerve, it's not just about your routine endoscopic sinus surgery. It's not just about skull-based surgery. It plays an important aspect as far as defining surgical boundaries, surgical margins are concerned. And it also plays an equally important role when it comes to approaching orbital tumors. So there is a whole lot of optic nerve, because many a times as skull-based surgeon, all the emphasis is on internal carotid artery. But I believe that just like the internal carotid artery, optic nerve has to be given its due respect. So I would like to acknowledge few people before I conclude my talk. My professor, Dr. A. Ravikumar from Chennai, under whom I was trained. My mentor, Dr. Nishit Shah, under whom I did my fellowship in Bombay Hospital. And Dr. Janki Ram sir, whom I have been following and whom I have been associated with for, I think, more than 10 years now. And he has been actually a true friend, a wonderful teacher and a wonderful person. And I would like to again thank him for this opportunity. And I would like to thank my neurosurgeons, without the help of whom I would have been able to present these kind of cases. And I would also like to thank my assistant, Dr. Nidhi, who has worked tremendously in getting me all this data for this presentation. And with that, I would conclude my talk. And thank you so much. Yeah.
Thank you, sir, for this was a very exhaustive and very informative lecture, sir, on all about optic nerve from A to Z. You have covered everything in optic nerve, sir. Thank you, sir, for this an enlightening lecture, because this would, I think, probably inspire many young ENT surgeons to take up the endoscopic sinus skull-based surgery, sir. So thank you one and all, sir, for all this lecture and taking a time from your busy schedule and giving a lecture to us and to the world. You have been watched by not only in India, by all over the world, sir. If you see the comment section in the Facebook, sir, you can come to see that your lecture was commented as superb and wonderful lecture on optic nerves, sir.
Thank you.
Thank you. Many people from all over. Yes, sir.
Just sign off. I would like to actually at the last slide that I put up here. I'm
yes, sir.
most of you familiar with him. So,
everyone knows the neck.
I believe all Indians are proud of him. So with
Yeah,
that, I would say thank you for the wonderful evening and the opportunity.
Sir also conveys his congratulations for this lecture, sir. You rocked actually the optic nerve today, sir.
Thank you so much.
And to others, we will continue to get more academic sessions from Royal Pearl Hospital in the various fields of ENT, from the legends directly to your house. So you can enjoy all the lectures sitting at home in your couch. And so thanks for everyone joining us today on this Sunday in this academic feast and making this program a successful one. Thank you and good night, sir.
Good night.
Good night. Thank you.
Good night, ma'am.